1. Please start, ma'am. We are live.
Yeah. A very, very warm welcome and a good evening to all the distinguished and esteemed guests. At the outset, thank you for your gracious presence in the scientific endeavor, BemTalk. BemTalk is our virtual platform to unlock the scientific aspects of bempedoic acid. Doctor, we at Zydus are truly dedicated to life in all the dimensions. Today, Zydus is the 5th largest pharmaceutical company in India and aiming to serve the society, nation, and the whole world with its innovative, quality, efficacious, and affordable drugs. In our quest to unite against dyslipidemia, a new hope has arises after 20 years in the form of bempedoic acid. Having said this, I would like to invite our esteemed speaker for today's BemTalk, Dr. Kavita Tyagi, to set the ball rolling for today's BemTalk. Dr. Kavita Tyagi is a consultant cardiologist with the 3 decades of rich experience in the cardiology segment. She has worked as an assistant professor in the Department of Anatomy at National Institute of Medical Science, Jaipur. She has worked as an assistant professor in the Department of Anatomy at Medicity Institute of Medical Care, Medical Sciences, Hyderabad. Moreover, she has also worked as an assistant professor in Department of Anatomy in MGM Medical College in 2009 to 2010. She has worked in Cardiology Department of MGM Medical College again during 2010 to 2011. And she has worked in SR Mehta Cardiac Institute during the time 2011 to 2012. And she has worked as an associate consultant cardiology, electrophysiology, and pacing Fortis Escort Heart Institute, Delhi. And she's also worked as a fellow of National Board and Intervention Cardiology, Max Super Specialty. There are many more accolades which is attached to Dr. Tyagi's CV. She's a member of many national as well as international societies, and she is author and co-author in many national and international journals. There are many more things which we can talk about Dr. Tyagi. So Dr. Tyagi, over to you. Please take us through the bempedoic acid talks today. So over to you, Dr. Tyagi. Thank you. Yeah.
Allow me to share my screen, please. Allow me to share my screen. Yeah. Okay. Yeah. So thank you so much, Pallavi, for inviting me for the session. And a special thanks for Mr. Vishal, who has been working really hard on the matter. So I'll be talking about bempedoic acid, for which we all are really excited because we all know what the problem of LDL we are facing day in, day out. So bempedoic acid and uncontrolled LDL cholesterol, unlocking concept and unleashing the efficacy. So we know that dyslipidemia is always a major concern for cardiovascular events. If we see our inter-heart study results, you can see that we know that smoking, fruits, vegetables, lack exercise, alcohol, hypertension, diabetes, and all these things, they are very important 9 risk factors which are almost responsible for 90% of the heart diseases, but lipids constitute 50% of all of them. So we can clearly understand that lipids are very important for controlling our cardiac diseases. So for cardiovascular disease prevention, primary prevention trials, statins are the drug of choice. And we have many trials, many old trials to substantiate to this, wherein these are the names of trials, when we have seen 37% reduction in non-fatal MI and 36% reduction in non-fatal MI in this trial, 37% in this trial, etc. So we have seen clear-cut reduction in fatal or non-fatal MIs in primary prevention by use of statins as well. For secondary prevention also, statins are obviously the drug of choice. So we have many standard landmark trials like lipids, care, miracle, lips, prosper, etc. And all of them, they clearly showed the clear-cut decrease in cardiovascular mortality and morbidity by the use of statins. So management of dyslipidemia is most on priority, and statins are first line of therapy, obviously. But our concerns are few, like do all statins users achieve LDL cholesterol as per guideline recommendation? Number two, how to achieve LDL cholesterol target after maximally tolerated dose of statin? So clearly, we are using the statins as a primary and secondary prevention, and statins are the first line of therapy. But are we able to achieve the goal which we want? And are we able to use statins after maximally tolerated dose of statin, whatever LDL we reach to? So if we see the concern number one, that is, do all statin users achieve LDL cholesterol as per guideline recommendation? If we see the guideline recommendation, we will go through the guidelines and we will understand that LDL level recommendation is different for different group of risk people. So if we see this flow chart, we can see the various trials for different products which are suppressing your LDL, like PCSK9 inhibitors, statins, bile acid sequestrants, niacin, and fibrates. But all of them, they have their percentage of reduction of LDL. Now, if we understand that how much LDL we need to target. So if we see European Society of Cardiology 2019 target, for very low risk people, we can tolerate less than 115. Moderate risk, we should have LDL less than 100. High risk, we should have LDL less than 70. And very high risk, we should have LDL of less than 55. So as cardiovascular risk increases, we need to reduce more and more LDL down. Now, if we see the slide, we have a clear-cut defining criteria as where a person is considered moderate risk, high risk, and very high risk. So very high risk, as we saw in the previous slide, wherein we require LDL to be reduced to less than 55. So we have familial hypercholesterolemia with atherosclerotic cardiovascular disease, or with another major risk factor, or severe CKD, or diabetes mellitus with target organ damage more than 3 major risk factors, or early onset of type 1 diabetes, or longer duration more than 20 years. So in this subset of people, we require LDL less than 55. If our patient is in high risk group, like the moderate elevation in single risk factor, particularly triglycerides, total cholesterol 310, and LDL around 190, or blood pressure is very high, or familial hypercholesterolemia, or moderate CKD, or diabetes mellitus with target organ damage, or diabetes mellitus with duration of less than 10. So clearly, we have our day-to-day life clinical practice patients are full of this kind of people. So we need to define them whether they are fitting into very high risk, or moderate, or low risk. And depending on, we have to teach our patients how much LDL they are required to achieve. So based on revised European guidelines 2019, how many patients do have controlled LDL? So if we see this study, the Da Vinci study, it's a cross-sectional observation study, wherein 18 countries were studied and total number of patients were around 6,000. And we could see that only 27.2% eligible patients are receiving high intensity statin. 33% patients achieving lipid goal with high intensity statin. So we are very much behind our desired aim. So we can see this now. The Da Vinci study showed that the statin uses in very high risk ASCVD patient, 37.5% eligible patients are receiving high intensity statin, and 18% patients achieve lipid goal with high intensity statin. So clearly the gap is huge. Now, how much is clinically beneficial to attain LDL cholesterol? Target low density lipoprotein cholesterol, and secondary prevention for patients with acute MI, a Korean nationwide cohort study. So they studied 5,000 patients with prior MI, and LDL achievers definition was patients who achieve LDL more than 50% or LDL less than 70 at follow-up. And this is almost a standard definition of LDL achieve, what we want to achieve. The study endpoint was 2 years MACE, and median follow-up was for 2.1 years. So 94% of patients were on moderate to high intensity statins, and LDL cholesterol achievers were 22.1%. So let's say relative risk reduction was 37%. And to conclude that in patients with acute MI, achieving a target LDLc was associated with a lower incidence and a reduced hazard rate of clinical events to recur them frequently. Now, if we see this, so the people who could achieve their LDL cholesterol less than 70 or 50% reduction more than that. So they were least in number, that is 2.3% people reduction major adverse cardiovascular events. They got only these many events. So we can clearly see that those people who could not achieve LDL less than 70 and whose reduction was more than less than 50%, so they were higher in the list. Now, management of dyslipidemia is at most on priority and statins are first line of therapy. But now our second concern is how to achieve this target of maximum tolerated dose of the statins. So now we have fortunately other form of therapies also with us. So moderate intensity statin is defined as 30% reduction, high intensity is 50%. And if we add our azithromycin to high intensity, we can achieve up to 65%. Alone PCSK9 inhibitor achieve 60%. But all of us, we obviously know the limitations of PCSK9. It's an injectable form and it is very costly drug. If we can give PCSK plus high intensity, then 75%. And PCSK plus high intensity plus azithromycin, so we can achieve 85%. So obviously it is a very hopeful thing for us to have that even if we have people like homozygous hypercholesterolemia, possibly we can give them some treatment in an effective manner. So bempedoic acid is a ATP citrate lyase inhibitor, a first in class and LDL lowering drug. It is approved in the US, India, and approval year 2020. And it is approved for reduce uncontrolled LDL cholesterol with maximum tolerated statin dose in mixed dyslipidemia, familial hypercholesterolemia, high risk of ASCVD patients, statin intolerance or whom statin is contraindicated. And dose is 180 milligram orally, which will without food. So clearly, the people where we are giving maximum tolerated dose, but LDL is not controlled, or familial hypercholesterolemia, wherein the basic LDL is so high that it is difficult for high intensity statins also to achieve the desired level, and people in whom statins are intolerant or statins are contraindicated because of any reason. So we know that our statins, they work on this level, that is hydroxymethyl butyryl reductase inhibitor. And before this, one step before this, our bempedoic acid is working. So half-life is 21 years and 70% gets excreted through kidney, 5% through feces, and less than 2% excretion unchanged drug through the kidney. Now this is very important because all of us, we are starting the drug completely new. So renal impairment, no dose adjustment is required. However, it has not been studied in end-stage renal disease, so we do not know, and possibly we will not use it. In hepatic impairment, the same thing, adjustment is not required, but it has not been studied in class 3 liver failure. However, so these two things are not of much concern. People where they have high uric acid or prior history of gout, or patients more than 60 years of age taking corticosteroids, or fluoroquinolones with renal failure and a history of tendon rupture, especially tendon rupture, they warned of potential for tendon rupture and advise patients for rest at first sign of tendinitis or tendon rupture. Now, patients more than 60 years of age taking corticosteroids or fluoroquinolones with renal failure and a history of tendon rupture, in these, bempedoic acid is to be not given, and if you are giving it, then it has to be discontinued. So, or people who are taking already simvastatin, high dose pravastatin, in them use concomitant use bempedoic acid and consider lowering dose or switching to statin. Pregnancy, discontinue unless the benefits of therapy outweigh the potential risk to fetus. It is not recommended in breastfeeding. So clearly we have to, first thing is we have to take care of renal impairment and hepatic impairment, end stage and class 3. Then secondly, monitoring, we should monitor the people who are having high serum uric acid or some tendon issues, or people who are more than 60 are taking corticosteroids or fluoroquinolones with renal failure or with history of tendon rupture. In them, we have to monitor them. And patients, if they develop a tendon rupture, then it has to be discontinued, or if they develop any joint pain, swelling, or inflammation, it is to be discontinued. If they are taking other statins like simvastatin or pravastatin, then concomitant bempedoic should be used. Pregnancy, it is not indicated as for now concern, and breastfeeding it is not recommended.
Hello.
So,
Dr. Kavita.
to the Dutch diagnostic criteria, we have a,
Hello.
so we have first degree relative with premature CAD or vascular disease in men less than 55, women less than 60, or first degree relative with non-LDL cholesterol more than 95th percentile for age and sex, first degree relative with congenital or arthritis cornelis, or children less than 18 years with non-LDL more than 95 percentile for age and sex. So these are the basically criteria. They are given in the website and people can use it. Physical examination, if we find tendons and thomas, arcus cornealis, LDL cholesterol more than 330. So these are the different criteria to diagnose your patient, whether it is definite familial hypercholesterolemia, probable, possible, or unlikely. So bempedoic acid indication and phase 3 program is going on, in which various trials like Clear Harmony, Clear Wisdom. So in the Clear Harmony trial, it was for 52 weeks and 20 to 30 patients, in which ASCVD 98%, familial hypercholesterolemia 4%, hypertension 79%, likewise. And this is the clinical profile of Clear Wisdom. This is Clear Serenity and this is Clear Tranquility. So different set of people were studied in different these trials with the bempedoic acid. So in Clear Harmony, these were the people, 52 weeks, and all people were on the statins. Efficacy endpoint was % reduction from baseline at 12 weeks, and safety was studied at the end of 52 weeks. So the results showed mean LDL cholesterol compared to your placebo, 18% reduction, and total cholesterol 11% reduction. Non-HDL cholesterol 12% reduction, and apolipoprotein B 11% reduction. In Clear Wisdom, percent difference of LDL placebo corrected minus 17%, and Clear Tranquility, Clear Serenity trials showed they were studied for almost same kind of people, number of patients 269. It was 12 weeks and 24 weeks. And here patients were less, 32% on statin, 18% statin. Outcomes were same studied, and study results were showed almost 23.5% reduction by placebo here. This is the bempedoic acid. So percent of LDL reduction by bempedoic acid 12 week was 28% by placebo corrected difference. Phase 3 trial of bempedoic acid or ezetimibe alone or in fixed dose combination versus placebo. So patients at high risk due to ACVD or hypercholesterolemia with LDL more than 100, or multiple CVD risk factors with LDL less more than 130. All treatment added to stable background. Maximally tolerated therapy, no safety concerns. So clear outcomes, global CVOT trials. Now 14,000 phase 3 trial, clinical trial, current status enrollment is complete. And completion date will be December 2022, in which it is double blind treatment period LDLC. So primary endpoint will be visualization for at least 2 years. And ADA 2022. So does bempedoic acid reduce inflammatory CV risk markers? Because we understand that the statins are known for their pleiotropic effect. So clinical evidence, effect of bempedoic acid on hsCRP. We can clearly see percent change of hsCRP from baseline at week 12. So clear cut, there is a reduction in level of hsCRP. And pooled analysis of phase 4, 3 pivotal trials. Adverse events of special interest people, placebo 7. Gout, 33 people, placebo 5. And increase in ALT, your SGOT-PTs, 18 in comparison to 3 on placebo. Anemia, 60 patients in comparison to 19. Tendon rupture, 6 in number, while there was none in placebo. And new worsening or worsening diabetes, 96 in number, while it was 67. So it was basically to come, and it has come along with the use of drug. And so to summarize about bempedoic acid, uncontrolled LDLc is a major risk for any type of dyslipidemia. Even after high intensity statin, 70% patients have uncontrolled LDLc and increases residual CV risk by 60 to 70%. So bempedoic acid is the first in class agent having unique mechanism of action of ACL inhibitor. Significant LDLc reduction up to 18% from baseline as an support therapy to statin, and safe in mild to moderate CKD patients. Hyperuricemia and gout are common adverse events which should be monitored on a regular basis. So thank you. Thank you so much.
Thank you so much, doctor.
बस मैं आ रही हूँ 5 मिनट में आ रही हूँ 5 मिनट में हाँ जी मैं भी उधर ही मैं आ रही हूँ
Yeah, thank you so much, doctor. Thanks for this really very informative talk which you have given on the BemTalk. Ma'am, there are few questions or the queries that doctors have asked. If you're with your kind permission, may I ask you those? Yeah. So, ma'am, according to you, how low is very low with respect to LDL cholesterol level? This has been asked by Dr. Joshi, based at Mumbai.
Yeah. So basically, LDL. Yeah, the people have a lot of concern like LDL low, it might be problems. But LDL, even if it is up to 30, you know, some people consider that they should achieve LDL as low as up to 30. And when a newborn, if you see the LDL level of newborn, so it is actually very low. Only by our dietary habits, or even if it is familial, then it increases. So up to, I think, 30, there should not be any harm, whatever we have seen so far clinically.
Yeah. Thanks, ma'am. The next question in this is, if the patient cannot tolerate the minimum dose of statin, will bempedoic acid will help to reduce the additional LDL cholesterol level? This has been asked by Dr. Ghosh, based at Siliguri.
Yeah. So yes, it is basically one of the clear-cut indication in statin intolerant patients. Bempedoic acid should help us. That's what we are expecting from
it. Thanks for that answer, ma'am. The next question is, how suitable will be BemTalk for Indian population when the statin is the first choice for Indian dyslipidemia? This has been asked by Dr. Shetty.
Yeah, so it should be actually able to Indian population, because Indians have been quite tolerant for statins also, barring from some social inhibitions that people have their own understanding about the things and Google searching, and then they come up. Really do not have understanding of, you know, the risk category, the high risk, the moderate risk and low risk, that they need to have different levels of LDL depending on the risk factors. People don't understand that. So that understanding has to be built in the society in general. And people who are tolerating, less statins, I think they should be good with this. Of course, we have to be careful about this tendinitis, inflammation, pain, and end stage of kidney disease and liver failure. However, we are starting to use, so it is only time to come which will teach us.
Okay. Thanks, ma'am. The next one is, can it be given with the PCSK9 inhibitors and what should be the expected result? Dr. Mehta, based at Ahmedabad.
Yeah, so PCSK9 inhibitor is itself not that user-friendly in terms of, because it is costly, it is an injection. And I guess PCSK9 inhibitor is itself very effective molecule, and in homozygous hypercholesterolemia, yeah, we are using it in many patients. And we are achieving desired results also. But in them, on clinically basis, we have to use and see, because so far we do not have any experience to talk on that.
Okay, ma'am. The next question is, can it be given with ezetimibe without initiating statin treatment? Dr. Muchalla.
No. Our first treatment should be started with the statin. If people are not able to achieve the LDL level, or if people are not tolerant, or whatever reason, then we should switch on to it.
Okay. So the question is, ma'am, can it be given along with bempedoic acid and ezetimibe? You were saying that we should be first starting statin, then you can add bempedoic acid, and if it is not even getting controlled, then you can even add ezetimibe. Is that so, ma'am?
Yeah, so now the current, our modus operandi is that we start with the statin, and we have ezetimibe, very user-friendly, cost-effective also. So we are giving you these two molecules routinely. PCSK9 inhibitor, yes, we are giving for our homozygous population, in which LDL level is really very alarming high. Now with this bempedoic acid in hand, I think we will start with the statin, and we will try to use either bempedoic acid or along with the ezetimibe. In people who we statin and ezetimibe, yes, we will add on now bempedoic acid. We will start this practice now.
Okay. Ma'am, next is, in patients with high LDL cholesterol who are intolerant to statin, what should be our treatment approach? Dr. Biswajit.
See, if it will depend on your LDL levels, it will depend on whether patient is homozygous or heterozygous. In homozygous, clearly we should be starting with the PCSK9 inhibitor. In heterozygous, starting with your lifestyle modifications and all those things. We now have a molecule in our hand, so we should start bempedoic acid along with ezetimibe. Yes, we must start now.
And the next question is, if we have to prescribe bempedoic acid in hyperuricemic patient, how frequently should we monitor uric acid levels? Dr. Murthy.
So clearly, they are saying that it should not be prescribed. However, if we need to prescribe, then I think we can check uric acid maybe once a week, and we can decide whether we can continue or not. However, there are no guidelines onto this, but our clinical experience only will teach us.
Right. Can it be combined with any statin therapy, ma'am?
Yes. The people in whom is not achieved despite statins, the maximum in those, it is one of the indication. So in them, after statin, we should add on bempedoic acid.
Ma'am, the next question is, as bempedoic acid reduces the new onset of diabetes or HSCRB, can it be suitable option for the pre-diabetic patients? Dr. Abhijit Kumar.
That is difficult to say, because in the table of adverse effects, we have seen that a number of people have converted to diabetes mellitus with the use of bempedoic acid as well. And it is said that with the statins also, those people who are already in the pre-diabetic, they were just to get diabetic, they were just, I think, maybe triggered by, okay, it has become diabetic fast, that kind of situation. So I don't think that is completely safe from the diabetic point of view. But yes, if we have to give it, then we have to give it.
Okay. Ma'am, the last question in this, what is the warning level of serum creatinine when bempedoic acid cannot be used in male or in female?
Secret stage 5. End stage renal disease.
Ma'am, what is the serum creatinine level you will consider as a warning sign for usage of bempedoic acid?
Maybe up to 2. Not
Okay. Okay. So thank you so much, ma'am. That's all the questions. So looking at the number of questions, I'm sure that you must have understood that a lot of doctors want to get clarity on the bempedoic acid. Ma'am, it gives us a great honor and privilege to propose a vote of thanks to our eminent doctor, Dr. Kavita Tyagi, for her excellent deliberation. I would like to highlight that there were close to about 500 doctors across India have attended and benefited with this academic initiative. This scientific initiative is brought to you by Zydus, who are the maker of BemTalk. Ma'am, we are very proudly say that we are the first company who have initiated we have bought bempedoic acid here in India, and we are the first player who is available across all the major and important counters of the pharmacies and the chemist shop. So, ma'am, wherever possible, I would request you, please extend the benefit of BemTalk to your patients. Thank you, ma'am.
Thank you so much.
Thanks and have a great evening.
Thank you.